So I would like to give people an opportunity to ask questions of our last two panelists first, and then I've been all morning thinking about how to knit this panel together, and I think that will be a very challenging thing to do, but there was so much incredibly important information and ideas that I think very appropriately here were asked really in the form of questions, and so the most important part of the learning here, I think, will be in the conversation. So I would invite people to step up to the microphone to ask questions of our last two speakers, and depending on how that goes, then I will jump it in and try to keep things moving along. Does anybody want to? Yes, please.
Yes, this is a question for Professor Rosenthal to ask Dr. Gluckman.
Because I might need a translator.
Yeah.
I think I know what this one is.
Yeah. So Providence Health Plan and a number of other plans, they have a whole variety of payers, federal, state, private health insurance. And Professor Rosenthal wanted to ask you, how do you deal with vertical integration as you termed it? That is, all these different payers have different incentive systems. How do you deal with that?
Yeah, so that's actually a big challenge today, is that we have quality performance metrics that we're asked to report on. The Medicare side, so there's something called the Star Rating Program. There's Medicaid has a whole other set that's unique to Oregon. Some of them are homegrown, actually, never been validated, so that's kind of interesting. And then on the commercial side, there's accountability that's going to be increasing now with the marketplace, with the exchange, and that's yet to be defined. There's going to be something called a QRS for QHPs, it's a quality reporting system for what's the Q of the HP?
No one knows.
Qualified health plans. And so, and you want to get harmonization. But one of the other things, though, I would also say is that those payers also have the responsibility for caring for diverse patient populations, and so some differences in the measures are actually important and relevant. So there can be some that are the same, but there are going to be some that are unique, because no one would ever imagine that you would have the same quality metrics for an elderly population that you would for children, or that there might be some unique measures that are needed for people with special challenges, such as being challenged by the burden of poverty or the like, and some of that stuff is difficult to quantify or to get at the plan level. So obviously, as a health plan, I just have to take what comes. We can have influence. They ask us our opinion, and sometimes it actually makes a difference. I think that we do have a little bit of a voice, but I wouldn't overestimate how much voice we have. But we have some, and then it's our job to kind of translate that to practitioners into what are the priorities and what are the ones that are most important, and how do we help them? How do we help them get to a measure? So I'll give you an example. In Oregon, in Medicaid, one of the requirements was to start the report on something called an SBIRT, which is screening, brief intervention, and referral for treatment for alcohol use and chemical dependency, substance use. So, and that went out there. And what did we do as a plan? We actually did this for many CCOs and with many CCOs. We developed training sessions throughout the state of Oregon. And we developed a common billing code so that people could actually capture it, and we kind of worked with other payers around that, so that there would be the training and education about what actually has to be done, and two, how can you capture the information in a way so that you could administratively collect the data. So I think that plans had a special role in doing that. Now the state of Oregon has this transformation center, and so they do some of that, but I think that was an area where we collaborated. I do think that when the measures get too unwieldy, we have to listen to providers, and we have to be realistic about what's actually achievable. And there will be times that not every measure will be met. And I think that there's also some awareness and recognition that that what gets measured tends to be what gets done, and measures aren't going to be capturing necessarily all of what needs to be done for patients. So we have to have some humility about that as well. So what I would say is, get harmonization when you can, recognize that there's some unique populations, try to have some understanding of what clinicians can actually do, and press hard on the areas that are most important.
Great, okay. Yes, please go ahead. I have questions too, but I'm definitely interested in hearing from people.
Dr. Gluckman, one of the things that single payer advocates like to point out is that the administrative costs for Medicare are quite low, 5 to 6%. What are the administrative costs for, you talked about the administrative costs in your lecture, and that's $20 to $30, about $30.
Yeah.
So what percentage are the administrative costs for the province?
So overall, our administrative costs are, and I can tell you before 15, because I know that number off the top of my head, 8.6%, and then there's a little profit margin, which has generally been running, 0 to 2%. Most payers in Oregon this year are going to lose money. So our medical loss ratio, which is the amount of premium that's spent on medical care, tends to run around, for over the entire book of business, around 89%. But one of the things that you said, and I tried to point this out in my talk, is that whereas the Medicare administrative costs that Medicare measures doesn't include the burden of a lot of the things that practitioners still have to do, like fill out a how many page report, for a nursing home each month, or what's the documentation requirements to build a transition of care code, or how many bullets do you have to put in your review of systems for, that's the insanity that Dr. Lowe was talking about. And I think those are hidden issues. And then the other question that I would just kind of push back on is we also invested a little bit in reducing variation and improving quality, and I showed you some examples of that. And Medicare has not really done that. And so that actually does cost some money. And then we also have the responsibility as a plan of having, customer service people who actually can ask questions, like Dr. Slusher was pointing out, but lots of luck calling healthcare.gov to get you an appointment with somebody, with a provider. So, I think that you raised the point that if payers, I think that there should be as much transparency as possible about medical loss ratios. And I would love it if providers actually said, we're not going to contract people whose medical loss ratio is below a certain amount because too much of it's going to administrative cost and profit. And we should absolutely be held accountable for the amount of the premium dollar that is not going for medical care. But it's not all rosy with single payer.
Great, thank you. Sir.
Can't you ask him a question?
No, go ahead. You're doing well.
My name is John Evans, and I do have a question for Dr. Lowe.
Uh-oh.
The EMRs that interaction with, they have allergies and other things where misinformation is routinely hardwired into it by people that may not be as genetically sophisticated. You can't change it. It has been pop-ups that come up basically where you have to contradict what's there. They extrapolate, let's say somebody gets nausea with Vicodin, then every known narcotic, you're basically saying, the record is saying that you are overriding something. Are we creating a huge liability problem down the road with this hardwired protection for whoever is working the EMR?
Well, I'm in. I think that we're going through a transition. Think about the late 19th century. The first cars and the first automobiles came out, and they weren't working properly. Were creating liability, and eventually things got figured out. But the answer is, how else do you learn? I think that we are very premature to push thousands and thousands of physicians into soft systems that have not been truly tested yet. And not because they were bad systems or anything like that, but because, again, in this business, we know what we know, but we don't know what we don't know. And we can only find out by making mistakes, except that you don't want to do it with everybody at once. So, but it is what it is. We are there, we're in the game, and all I can say is amen.
I'm going to add to that, John. What we're really talking about is that, those systems are there to trigger a clinician to think about what they need to do. They're not there to tell a clinician about what they need to do. It's the same issue about a guideline. guidelines are guidelines, they're not rules. But if you deviate from a guideline or deviate from that override, it's important to document why and that you paid attention to the fact that you thought that there might be a reason why why this might not be the right thing for that patient. And then you have to justify what you have to do. That's more important than the 9 bullets of the review of systems. So
yes, that's true, except that takes time, doesn't it? And effort and stress.
But the risk is, and I'll put, the risk is that if you don't adhere to a standard or a guideline, patients get harmed.
Right.
And so there's the balance of harm, and how many times a day do you have to do that? And so we have to have efficiency,
right.
And I agree completely about efficiency. But I think that we have to have triggers and tools to help people and guide them to the right decisions.
Right, except that if the physician gets overwhelmed, patients get harmed too. And so it's a situation where doctors act. There is, as I mentioned earlier, an alert fatigue syndrome. And doctors are just going at high speed with all these systems, and they're spending more time with the patient, with the system than with the patient, and they're missing things, and they're harming patients indirectly. I think that less is more. It's what I was mentioning, information versus data is noise. There's a lot of noise in those systems, and they're going to be improved. They will.
Absolutely, and then I want to add on to your question too. Go ahead. So I was just going to ask sort of an extension. I claim absolutely no expertise on anything related to electronic medical records, but what I heard from you very clearly was the importance of thinking about the electronic medical record as a tool for helping physicians treat patients. And I wondered, when you think about electronic medical records as a tool for learning about what works, what is critical for that? So you talked about how hard it is to look retrospectively, but we do have this expectation that we can use the information that is somehow systematically collected to then learn. And so I wondered about your answer to that.
I didn't have a chance to really expand on that. I mentioned Atul Gawande very quickly. As you all know, there are two kinds of errors in medicine. Random errors and systematic errors. And Dr. Gawande is absolutely right on the target that most of the clinical errors that we make in medicine are random. They're products of human error. We're human beings, right? Errors that we would make with the next patient presenting with the same situation. Errors that we blame ourselves in the middle of the night for having made. We're human beings. Then there is the systematic errors, which also exist. The systems, of course, are very concerned about the systematic errors, and they've abandoned the most common, the ones that the recipsaloquitur errors, the ones that indefensible ones, they put them secondary. The software should do both, and a good EMR should be able to adapt the systematic errors and change your habit, if you're willing to change your habit, and then not bother you anymore, but let you do it your way. And by the way, because I think that ultimately medicine is an art. Now, I have a very specific definition for that. When I mean that medicine is an art, I mean that not two providers do it the same way. And it doesn't mean that one is better than the other. There are different ways to practice this art of medicine. By doing it your own way, by practicing medicine your own way, you will be practicing better. The software has to respect the way you think of medicine, the way you practice medicine. At the same time, I think the vast majority of doctors want to learn how to improve their practice. They welcome information. What they don't want, what we don't want, is to be managed by remote control. There's a big difference between those two. So I think the computer can be a great liberator or a great enslaver. I don't know if you remember the Super Bowl advertising of Apple in 1984, which opened my eyes and many other eyes, I'm sure, where Big Brother, which Big Blue, IBM was the enslaver, and then this genie came in and broke the bottle. Famous, $1 million ad in those days, which was a fortune, and he made Apple. But basically, the computer can be your liberator if it's programmed properly, all right? And by the way, software is biased. The question is it going to be biased in favor of the physician or against the physician? And it's not because they mean badly. Nobody in this business means to harm or to do badly. Everybody knows what they know. The problem is that we're not having too many meetings like this one where really the information can be exchanged. I don't even claim to know what I know. But I know that nobody else does either, so that's okay. All right?
Please.
I just wanted to ask you, Dr. Rosenthal, about how should specialists be engaged in ACOs? You had that on your slide, and since you have experience with ACOs around the country,
Great, thank you for that question. And Cheyenne and I actually have spent a lot of time thinking and talking about this. And so you can imagine in an ACO environment, let's say the ACO actually has data that are useful and provide some information about where the opportunities to better manage patients are. And just to make it easy, the example of cardiology, patients with heart failure, those patients are effectively managed across the continuum of care. Cardiologists play an important role in that. Primary care physicians may be part of that as well. And so we've thought about, if you bring together a group to better manage these particularly high-risk patients and keep them functioning the way they want to be, enjoying their lives the way they want to be, and ideally out of institutional care as much as possible, who should get the reward for that? Is it the primary care frontline who maybe make more appropriate referrals, who work more closely with the cardiologists for those more fragile patients? Or is it the cardiologists who are essentially, in some cases, providing curbside consultation to avoid referrals, avoid testing? And what I've seen around the country has been a general reluctance to engage in finding new ways to change at least the financial conversation across these multi-specialty organizations. So there has been very little sharing of shared savings down at the individual physician level. But some groups that I know of have been doing this based on essentially a negotiation of allocating a portion of shared savings to one specialty group or another, where patients are clearly managed across those specialties. So on the one hand, if one doesn't give some of those shared savings back to the specialists who potentially are giving up visits and reimbursement on the visits, then that's clearly not sustainable. On the other hand, the other caregivers who may be keeping patients healthy through other interventions also feel a sense of needing reimbursement. And so I know that conversation has gone on a little bit in Providence. I'm kind of curious what you think, Cheyenne, at this stage is the right balance there, if I can toss that back out to you. Right, so certainly my guess is what won't work is if we think that a lot of savings are going to come from facility-based care and from sort of high-tech services, simply taking that money out of that part of the delivery system without collaboration, engagement, and sharing of both the costs and benefits, that will not be sustainable. And I think that's a little bit of the unraveling of managed care in the late 1990s was not making those arrangements correctly. But as far as I can see, no one's really figured out the magic way to do this at the margin as we're changing. I think there are organizations like Providence, Kaiser, others, where the group ethic and the norms of working together exist and have existed for many years, and these things get negotiated largely on non-financial terms, but having to do with culture and collaboration as much as anything. So, yeah, please go ahead.
This question is for Dr. Gluckman. Just to play devil's advocate, you indicate that a multi-payer system with is more more nimble and increases competition from the shelves, make things better. How do you explain that costs are higher in the U.S. while outcomes aren't better necessarily than countries with
So the biggest issue about cost of care in the United States is the price. It's not so much around utilization, but there is utilization opportunity, and the issue around price is more complicated because of, as I alluded to, in the United States we already have more income inequity. So there's a societal piece about that healthcare is not immune from. If you look at physician incomes, as Dr. Cleary pointed out, they'll be substantially different, especially in the specialty areas as opposed to primary care. But there are other factors in play, like the cost of an education that is not borne by the individual in other countries. I think that tort is an issue. Although when you look at the cost of the tort reform of tort in the United States, when you look at the percentage of malpractice premium, it's relatively low. It's very difficult to quantify what is defensive medicine and what is not. But what cannot be denied is that doctors think about it all the time, and there's an emotional strain that exists that doesn't exist to the same degree in other countries. And somehow that has to be reduced to get people to also maybe think that I can do this without having to have this much larger monetary reward. I think there are some differences around resources, though, that we spend a lot more money on the end of life. Access to high-tech services in the United States has much fewer limits. I mean, there are stories of Canadians having to come across the border. There are things that are certainly, I imagine that the use of high technology like a defibrillator in the octogenarian population in other countries is going to be somewhat different in the United States. And there is a cultural difference in the United States that also happens to just be different. That and I'll quote Jock Murray as a Canadian. He was a past either president or chair of the Board of Regents of American College of Physicians, and he said every healthcare system has three components, and it's everything for everybody right now. Pick two. Yeah, and so in the United States, everybody was not a factor, so it's everything right now. And so there is going to be a balance, and there are some societal issues about cost. I think that price is the biggest factor, and with government, regulation, you do get price control, and that may be a factor here that's going to be coming up more and more. I also think that if anybody who's in a practice here said if I had to exclusively manage my practice on a Medicare reimbursement, what would happen? And having managed practice budgets before in primary care, I happen to know that the I believe, I shouldn't say no because I've been out of that, but probably the income level for a primary care doctor would be somewhere between $0 and maybe $25,000 or $30,000. So because that rate is actually probably too low for, at least in primary care, for the face-to-face visit stuff. So I think it's a complicated issue. I actually do think that you can try to say we're going to set some global budgets. And Medicare Advantage is an example of single payer but administered by insurers still, and that's the mechanism in France, not in France, in Switzerland, or in Germany, where they have sickness funds and they have insurers. So it's not be all around, they're not mutually exclusive. I mean, I do think we're going to get to a point where global budgeting, and we say we're going to live within this budget, and then we're going to have to say what can we deliver, and can we empower things in such a way so that we can get either some rationalization about what's value, and what can we say this service is of insufficient value to provide it all the time. And that's not part of the American culture. Can we re-import drugs and pharmaceuticals? I mean, can we get acquisition cost of an MRI? Part of the reason why it costs less in Japan is that they can buy an MRI machine for a lot less than you can buy it in the United States. And so some of that's going to have to, sort out over time. And I get some nods, so I'm not saying anything that's scientifically incorrect, I think.
I'm going to take the next one and just warn you. I really wanted to leave Dr. Lowe's last slide out because at the end of the panel, I wanted you all to think about, I was trying to think of, again, how to cut across this incredibly talented and varied panel, to think about that future that you would envision. Because I do think in some ways it's very frustrating for us to all talk about these incremental changes, given that as they all fit together, they perhaps create more noise than move us in the direction of that future that we would like to share. But if everyone at the closing remarks could say something about what that future looks like, and from your perspective, thinking from the research perspective, what is the biggest obstacle to getting to that future healthcare system that you'd like to see? Go.
Hi, Fred Andres, I'm a surgeon here in Portland, and just wanted to comment on something we're involved in, and then kind of get the panel's thoughts about it. So we just started the Medicare bundle program for total joints, and probably nobody knows what that is. Basically, we're involved in determining, they give us a flat fee for total knee replacement. And that includes pre-op care, not the in-hospital care, that's the hospital separate from ours. And then 90 days post-op care. And if we can take care of that patient and under that flat fee, the savings is split between Medicare and us. And it's the first time ever in my memory, I guess 14 years on medicine, where someone actually asked me, and it's the government using the street. And you made a comment about it, it doesn't relate to fields, which I get, but I wonder if the government is going to be more willing, or is this going to go away in 2 years? Because I can't think it seems to work well for it to go away in 2 years. Or do you think this is going to last, number one? Can we study it, number two? And then I guess the question is, how can we relate this to other fields? It seems like any procedure-based field could have fun.
Right, yeah, absolutely. So my very first research assistant job 22 years ago was to study a bundle payment initiative that Medicare was attempting for cabbage. And it was incredibly successful. It saved money. And the most important thing is the cardiothoracic surgeons actually spoke to the hospital administrators, and they talked about how they could make the care better and more efficient, and outcomes were better. And Congress said, no, we can't do that, because that, what was involved in actually institutionalizing that bundle payment was politically challenging, because it couldn't be done everywhere. And so 20 years pass, and we're trying it again. So the hips and knees bundle payment for Medicare is now, in theory, permanent, even though it's not everywhere. It's market by market, depending on the size of the market. And I think all the data that I have looked at suggests that it can be successful. But as you get to more complicated kinds of care, particularly when we talk about medical management of patients with heart failure, patients with other complex medical conditions, bundling gets more challenging because of the variation in risk factors and variation in costs. So I do think bundle payment is likely to stay for certain kinds of care, for procedure-based episodes of care, and it can really make a difference, I think, especially where post-acute care is a significant part of the overall bundle, in those bundles that include post-acute care, but even just the physician hospital being paid under a single bottom line, which is the Medicare policy. It may get allocated by the hospital, a chunk to the surgeons, a chunk to the facility, but I do think that that kind of bundling encourages a coordination that we haven't seen. We still have a lot to learn from that. So I don't know, this is a good example of Medicare policy change. These things happen lumpily, and they get rolled out. In this case, there's a geographic experiment underway. So what do you think, Amanda, about learning from that?
I didn't know exactly where you were going to go.
Yeah. Oh, that one
ones.
doesn't work.
I'm all for studying natural experiments when that's all we're able to do. I might as well try to answer the question that you posed: is how do we change the future? I think the big thing that we need to do is we need to set up the incentives so that we all work together. I noticed that a common theme of Dr. Lowe's presentation was just that people are talking at each other instead of talking together, and I think the big task for us as economists and us in health policy is to try to get everybody to be on the same team. And then once we have incentives that are aligned to increase quality and decrease costs, then small incremental changes are all worth implementing. We can all start thinking on the nitty-gritty level to make health system change come from that level.
Thank you.
So I might want to just chime in, because
Yeah.
we actually have a 4-year history with bundled payments for total joint replacements. And again, pointing to my comments about a little bit about nimbleness before. The savings that we've achieved in this community, because quality is pretty good already,
Yep.
and variation is a little lower, is fairly modest. It's mostly most of the savings is in the post-acute change. And so you may be getting into, and that's where a community like Oregon may not do quite as well as some place where the variation is greater. But the other question that comes into play, and where bundled payments don't really work, is whether or not that care is appropriate to begin with, when you have something that is as subjective as pain, it makes it difficult. Now, I'd say we actually also did some symptom scoring of our patients through the bundle, and looking at variation about what were the preoperative pain and functional status patients before surgery and then after surgery, and there was some variation, and that could be an opportunity for reflection as to who needed what. But it speaks also to the need for really robust shared decision making. There's some
Right.
experience in group health, and a bundled alone won't do that. So it's got to be multiple interventions around, really we're thinking about how to make care better, more efficient, with better outcomes, but also appropriateness. So it's a multi-pronged approach.
So while you have the microphone, Dr. Gluckman, so in between here and your vision for a better healthcare system, what's the biggest obstacle, and what does that sort of Emerald City look like?
The biggest obstacle. So you want me to say like
But,
one
and you get
thing.
30 seconds because Dr. Clack's standing behind you with the,
Right.
the hook.
So I'm going to have 3 things. I'm going to talk about, I think that we actually commit to a global budget. We commit to transparency around outcomes and patient experience, and we do that in a way that's not judgmental, but that's empowering people to learn to do better. And then we have to have some discussion with society about agreement about value.
Dr. Lowe?
Yeah, I'm actually, if I sounded pessimistic about EMRs, I'm not. I'm extremely optimistic. I think that is one of the 2 revolutions that's going to happen in medicine, the other one genetic engineering, and they will change the landscape. If you own a roulette table in Vegas, you don't need an insurance company for that roulette table. You go to your bank. At the most, the bank is going to send a technician, because if that roulette table works well, you have no risk. All right? We're in medicine in the opposite extreme, because we don't know the risks. We don't know what health is. We are experts in disease, which is not the same thing. We define health as the absence of disease. Statistics will change that. Certainly not with most of the EHRs in the market today, but in the future, the EHRs will be able to do that, and therefore, I think that they will bring more value added to the people who give health, who provide health, to the providers and the nurses, and they will tend to eliminate the middleman, all those who are controlling and managing us, because the computer will do a better job.
Very good, and I think we're over time. Is that correct? So do we get one more? Because she stood there so patiently.
Can I just make one comment? So
Yes.
I just want to thank you, and Dr. Kowalski, I'm sorry. I wanted just to tap onto what you said. I'm a MBA student, healthcare MBA student, also a physician, and have been in multiple different realms in my career. And in each of the different spaces, primary care, or population health, chronic disease management, now on the health plan side, I'm seeing a lot of fingers pointing at other people. It's from the physician perspective. When I was in that role, it's the health plan's fault. They're the ones who are causing problems. When I was in population health, it's the patient fault. It's a system fault. The health plan blames the system for charging too much or negotiating too hard. So I can learn even more from the concept of stop blaming and stop blaming for anyone and work as a team. And one book changed my life, not related to my healthcare MBA, but as a part of it, is called Unaccountable by Martin McCary. I think it should be a required reading for every single healthcare professional, and in fact, probably everyone on the planet. But it's unaccountable what hospitals won't tell you, and how transparency can revolutionize healthcare. And it really did open my eyes to just pausing and reflecting on really who is it.
Thank you. Thank you. Excellent.
Thank you very
Dr.
much,
Clack?
everyone. Okay, we should give a big round of applause for our panel.